Hi there, my name is Hesham Abdalla. I'm a consultant paediatrician and clinical lead for quality improvement in Walsall. This year, perhaps more than any other, the Walsall Healthcare QI Awards are a marker of individual and collective excellence. The fact that we've had so many initiatives despite the pressures of COVID and the huge workload that we have been under is a marker of the fortitude, resilience and ambition of staff working in this trust. It's also been welcome to see that we have had QI projects submitted from all divisions and staff from nearly all departments in the organisation, which shows that QI is no longer just a fringe activity, but an essential part of all of our roles. There were 73 posters submitted. Some have shown an improvement and some haven't, but all have shown learning. And I think that the radical transparency that we have shown in posting them all on an engaging public platform is exactly what we should be doing. It avoids the publication bias of only publishing successful projects, denuding the potential of learning elsewhere. And it also shows that as an organisation, we encourage all to innovate and fail well in order to improve, showing that using a QI methodology, this can be done safely, quickly, and effectively. I'm delighted that by way of reward, there will be a prize for every contributor in the form of a pocketbook and QI. And there are certificates, books and monetary awards for the very best posters, which will be presented as presentations, which I encourage you all to enjoy. Many of these could and should be submitted to national conferences and peer-reviewed publications to celebrate what we have achieved. I remember when we first envisaged the QI Academy as a centre of excellence in teaching training, we hadn't envisaged the challenges that could be coming with COVID, but actually QI training has adapted very well to the virtual world. And there are a number of QSA virtual programs which I encourage you to enrol on. Saying that, after the magic happens in the discussion between delegates, and I'm delighted that today we're actually having the first of many face-to-face sessions back in place. And a final reflection, you may be aware that I will be leaving Walsall in the next few weeks to lead the QI team at Oxford University Hospitals. My reflection from that appointment process is that our team here at Walsall have a national reputation for excellence, and we have punched well above our weight in what we have achieved. I hope that you also benefit from your experience here, attend the QI training, become a trainer yourself, and spread the teaching and methodology of QI amongst your colleagues and peers for the benefits of patients and public. Thank you.
Hello everyone and welcome. My name is Maria Zupos and I'm a junior doctor within the orthopaedic team. I'm here to present the following QSA project alongside AMP Louise Pickering and consultant orthopaedic surgeon Fahad Hussain. We have named it Opiate Appropriate, a pragmatic approach to quality improvement for prescribing opiates and laxatives in hip fracture patient care. On average, one patient is admitted to Walsall Manor Hospital every day with a neck or femur fracture, NOF. These are typically elderly patients with a large number of comorbidities who require high-dose analgesia for long periods of time. This can result in adverse side effects including constipation, renal dysfunction and delirium, all of which impact their recovery and survival. Our starting point was the personal experience of our consultant, our AMP, staff nurses and junior doctors, but evidence in the literature suggests the same problem, although there is limited evidence as to how laxatives might be better utilised in this patient population. As part of a wider QSA project to reduce NOF mortality in the trust, we embarked on a smaller project to identify inappropriate opiate prescriptions to improve laxative usage and to therefore improve patient care by way of reduction of constipation. This slide gives an overview of the process this QSA project followed. There were 2 cycles of data collection carried out, with cycle 1 in January of 2021 being a retrospective data collection of patients admitted in the preceding 6 months, and cycle 2 being a snapshot of all neck and femur fractures admitted during 1 week in May of 2021. A number of interventions were carried out between the 2 cycles and focused on areas of change including education, documentation and systematic change. Data collected in cycle 1 included age, comorbidities, AMT, Nottingham hip fracture scores, the nature of prescription of the opiates and the laxatives, as well as enemas given. For the purposes of this data collection, weak opiate was codeine and strong opiate morphine. The results as highlighted in red on figure B show that 61.1% of patients received a strong opiate at a high dosage, with only 71.2% of patients prescribed regular laxatives on admission. 42.6% of patients went on to require a rescue enema during their stay, and days to bowel opening from admission were 4.5. As with any data collection, incidental findings were recorded, and in this case the following safety concerns identified. Regular high-dose codeine was prescribed to 7.4% of patients with renal impairment and to 18.5% with cognitive impairment. Only 7.5% of drug charts contained any documentation of weight, which is concerning given that prescriptions of paracetamol and clexane, amongst other things, are based on weight. So large volumes of regular strong opiates were being given to frail vulnerable patients who were requiring rescue enemas, rescue laxatives. Clearly a change was needed, and with the help of Consultant Mr. Hussain and AMP Louise Pickering, we brainstormed ways in which we could drive change over the next 4 months. Education was provided for all prescribers on the risks associated with inappropriate opiate prescribing, and the NOF clerking perform was altered to include checklist highlighting the need for prescription of laxatives on admission. Bowel chart awareness was also championed, noting patterns on the ward round and altering prescriptions accordingly. The results of Cycle 2 showed only 12.5% of patients in Cycle 2, as compared with 61.1% in Cycle 1 were prescribed a strong opiate at high dose, and 81.3% of patients were prescribed regular laxatives on admission. The number of patients requiring any rescue enema reduced from 42.6% to 5.6%. Please note that whilst the patient population sizes did differ from Cycle 1 to 2, the demographics were very similar. Data on initial loop closure suggests there has been a real clear change in prescribing practices amongst the junior doctors. Education we know leads to increased awareness of the prescribing risks, but in order to create a sustained change in the stressful and often time-limited system the juniors work in, documentation, reminders and ward round structures can help to facilitate changes. The results of this project would appear to indicate that prevention of constipation by prescribing appropriate opiates would be more beneficial to patients than prophylactic laxative prescribing or the use of rescue enemas, and these should be required less if prescriptions are more appropriate, i.e. prevention is key. Doctors need to improve consideration of patient renal function, document weights, and cognitive impairments. As we know, a snapshot in time is not an evidence of sustained change, so there is a lot more work to be done to establish that the outcomes are continuing to improve within the department, month on month. Further interventions might include changes to the clerking pro forma to highlight patients at higher risk of adverse events, and the use of a brightly coloured bowel chart could be used to aid recognition, as could pharmacy input on ward rounds. Finally, we have witnessed behavioural change in prescribing, but further work is needed on the measurement of other outcomes, such as time to discharge patients, rates of delirium, and reduction in mortality to measure the real-world impact our CUSA project could have. Thank you for watching, and I'd like to say a big thank you to Louise Pickering, who helped me to access and audit a large volume of data, and Mr. Hussain for helping to champion patient needs.
Hi everybody, my name is Le and I'm representing my team today. Thank you so much for this opportunity for us to be able to present our quality improvement project on the confusion assessment method for ICU, CAM-ICU. The confusion assessment method for ICU, CAM-ICU assessment tool, was developed to help with prompt diagnosis and management of patients with delirium in the intensive care. I'm sure everybody is quite familiar with the word delirium, which is characterized by an impairment in cognition, and it can often have non-specific manifestations. It may develop secondary to several precipitating factors and is often under-recognized by clinicians. Prolonged duration of delirium in ITU patients has been proven to have an increased risk of mortality significantly. Besides then, studies have shown that patients who are mechanically ventilated have higher rates of delirium as compared to their non-mechanically ventilated counterparts. And as we all know, most of the patients on ITU are being mechanically ventilated and are therefore at a higher risk of developing delirium. ITU delirium also contributes to long-term cognitive dysfunction, and therefore it is important to recognize and treat it promptly. The picture in the upper right is the CAM-ICU flow sheet, which is relatively self-explanatory, but I'll go through it briefly. The first question to ask is whether the patients got any acute change or fluctuating course of mental status. If they don't, they are CAM-ICU negative, which means that they haven't got any delirium. If they do, we'll have to move on to the second aspect, which is to check for any inattention by doing the things outlined in the box. If they make 0 to 2 errors, they haven't got any delirium. However, if they make more than 2 errors, we need to move on to the third aspect, which is to check for any altered level of consciousness using the RASS scale. So RASS stands for the Richmond Agitation Sedation Scale, which is used in ITU patients, as most of the patients have got some kind of sedation in the background. If the patient has a RAS other than 0, they are CAM-ICU positive, which means that they've got delirium. However, if their RAS score is 0, to move on to the last aspect, which is to check for any disorganized thinking by asking them the questions outlined in the boxes. Again, if they make 0 to 1 error, they are CAM-ICU negative. However, if they make more than 1 error, they are CAM-ICU positive. So it's quite a self-explanatory assessment to do. The objective of this quality improvement project is to assess the level of compliance of staff with the use of CAM-ICU assessment tool in the unit. 2 cycles of data were gathered between August 2019 to September 2020, capturing all the patients who were admitted to ITU weekly. Overall, 272 data points were gathered, and the analysis was made based on the following questions, which include, firstly, whether the patient was eligible for CAM-ICU assessment, secondly, whether the assessment was being done, and thirdly, whether the patient was CAM-ICU positive. Out of 272 patients who were recruited into the study, 77% of them were eligible for CAM-ICU assessment. Of these, 28% of them had their assessment done, of which 6% of them were positive. We noticed that there was a high percentage of patients who had incomplete documentation of their assessment, and this is what we aim to improve on. Based on our findings, we've made the following recommendations, which include daily use of the CAM-ICU assessment stamp as shown in the picture below, increasing awareness of staff in the department by educating them about complications of delirium, enlistment of staff as delirium champions, and the use of non-pharmacological approaches to reorientate our patients, such as putting a clock in every bed space, allowing for routine rest periods, ensure that eye and ear cover are available for patients, and also reduction in the noise level in the unit, and all of this have been implemented. In conclusion, a significant number of ITU patients have missed out on proper delirium assessment, which can lead to adverse impact on their care. We hope that with our recommendations, we'll be able to improve practice and care delivery. And that's it from me. Thank you so much for watching.
Hello and welcome to our audit presentation on the hypothetical application of the Neonatal Early Onset Sepsis Risk Calculator. This was an audit conducted as part of a regional study with PRAM, and my name is Afsa Sadiq. I am a paediatric doctor, and this audit was done in collaboration with Dr. Pooja Sidhi and Dr. Ravi Krishnamurthy. So just a little bit of background into our audit. So neonatal sepsis, we know in term and near-term infants, is actually quite rare at a rate of 0.5 to 100,000 births, but we know that it can be severe and life-threatening. Currently, we have NICE guidelines which recommends that we treat any baby with 2 risk factors for sepsis or 1 red flag for sepsis with IV antibiotics. And at the moment, we're treating 15 to 20% of infants on the postnatal ward. We know in order to capture 1 asymptomatic culture-proven sepsis, we need to treat around 600 to 800 neonatal infants. We know there's risks associated with early antibiotic exposure, and there's an increased tendency towards atopy and antibiotic resistance. So we were wondering if we can do this any better. In the US, they have this risk calculator, which has been developed based on the risk factors of over 100,000 neonates and their mothers to calculate a score for the risk of neonatal infection for the first 12 hours of life. And it then gives recommendations to not start antibiotic, actively observed blood culture, and or to just give antibiotics. In Wales, this has been audited, and it's shown that it could lead to a reduction in antibiotic treatment from 16 to 4.3%. This is the tool shown here, which can be accessed online. This is a close-up. So our aims of the audit was to assess the impact of hypothetical application of the calculator at 2 incidences, so 1 in 1,000 and 2 in 1,000. Then to compare these against the current NICE guidelines to see how they differ, and to evaluate the impact on postnatal antibiotic usage and postnatal bed days. Our method involved us collecting data respectively over 2 months and then hypothetically applying the calculator. The babies that we collected data on were over 34 weeks, did not require initial NICU admission, so generally were well, and had been commenced on antibiotics as per NICE guidelines. then applied the calculator score and analysed it both locally and regionally. Here you can see we gathered data on 53 patients. One was excluded due to born at home, and the majority here, as you can see, were term babies at over 37 weeks. So on to our results. This graph shows that actually nearly 75% of neonates were well without any symptoms. The remaining had one or two symptoms. Here you can see the maternal risk factors, and it shows actually most of the population started on IV antibiotics had one red flag. Very few actually were known GBS positive, and the rupture of membrane, prolonged rupture of membrane, was only seen in 6 patients. Maternal pyrexia was one of the red flags, seen in 31% of patients. We know after having done all the blood cultures that all except one blood culture were negative, and the one blood culture that was positive was felt to be likely contaminants. The majority of the babies had a normal CRP at 56%, and all the LPs that were done were negative. Antibiotic duration, as you can see, the majority were less than 48 hours. And here we have the outcomes of the risk calculator, which show a reduction at both incidences in terms of antibiotics. And here you can see how we compare to the NICE guidelines and regionally. So in conclusion, the calculator can result in a reduction of antibiotic usage and bed days, and we know that during the time the babies that we screened, no baby had culture-proven sepsis, and this was similarly observed throughout the West Midlands. And here you can see antibiotic reduction can be 88 to 81% depending on the incidence and how many bed days can be freed. Here is a graph which demonstrates how many bed days can be freed. So what next? The new West Midlands guidelines have integrated this tool into their guidance. We are now doing infection risk score training and have patient information leaflets. And even more so, the new NICE guidelines on early onset neonatal sepsis has endorsed the use of this tool. And thank you for watching.
Hello, my name's Tanya Granger. I'm Senior Sister at Walsall Sexual Health. I've been asked to present the following presentation for the QI Awards. Our quality improvement project was to provide postnatal contraception on the postnatal wards at Manor Hospital. We already had an awareness that there was an unmet need and that mothers would have difficulty getting contraception that they may require postnatally. This became even more relevant due to the COVID-19 pandemic, where new mothers found it increasingly difficult to access other services due to the restrictions. The delivery of the service was jointly designed by the CASH team and the Director of Midwifery, and this was to be a national first. The patients were all seen individually on the postnatal ward and offered contraceptive advice by the CASH nurse, and immediately provided with either condoms, contraceptive pills or contraceptive injections. Some women preferred to have a more long-acting reversible method, which would either be an implant or a coil, and these appointments were made at the sexual health clinic, and 98% of the mothers attended their appointments. The service proved to be extremely popular, with 1,213 women. An audit showed that one patient was under 16, 44 patients were 16 to 19-year-old, and this actually reinforced the collaborative working that we already have with the Walsall Teenage Pregnancy Team. We were able to see these young people on the ward and feed back to the team on the method of contraception and the interaction that we had had. 122 women preferred to have either the implant or the IUD fitted, and so appointments were made accordingly. One postnatal coil was fitted within 48 hours of normal vaginal delivery, and 45% were issued with point-of-care contraception. As you can see from the pie chart, the different methods of contraception that were issued, and the most relevant thing that we found here was the fact that only 1% declined any intervention. This was contrary to the belief that we had held in the beginning where we were informed that maybe young mothers wouldn't want to discuss about contraception when they'd just had a baby. In actual fact, it was the opposite. The service has received excellent feedback from the mothers themselves and also from the postnatal staff. The service has addressed an unmet need and improved the quality of the postnatal contraceptive service at the Manor Hospital. And this is an example of collaborative working between the departments, improving the quality of care for the women. Some of these women actually belong to very vulnerable categories and they may not have otherwise accessed any aspect of their care, Obviously, we're very proud of the achievements and we want to go forward and make improvements. This will include looking at the sufficient numbers of qualified staff that we may need access to, also any funding that we may need access to, and also providing a 7-day service, as currently it's only a Monday to Friday. Also training possibilities for midwives to undertake the LARCs, and also the provision of the subdermal implants on site by the cash nurses, and also to collect additional information from the users to further enhance the service. To summarise then, the provision of the postnatal contraceptive service has significantly enhanced the quality of care provided to mothers at Walsall Manor. This is evidenced by the excellent feedbacks received from both the mothers and the staff on the postnatal wards. It's also an excellent example of collaborative working to provide cost-effective delivery of contraceptive services, giving choice to all mothers. Thank you for watching.
Hi, I'm Karen Bendel, the Staff Engagement and Workforce Training Manager, and I'm here today representing the Workforce Training team from Learning and Development. I want to tell you about the fantastic work that they've been doing in making statutory and mandatory training more accessible for our colleagues. The aim of the project is to provide a user-friendly method that's easily accessible so staff have the knowledge and skills to provide high quality care to our patients. So let's give you a bit of background. So colleagues have historically struggled with ESR. They become very frustrated and find the system cumbersome. The frustrations are around sitting there for hours completing their e-learning modules, but it not to be recorded on the ESR system. This is very time consuming for the team due to constant calls and emails from colleagues telling us that they have completed their e-learning, but it just hasn't registered on the system. The team have to play detective. For them, it means going into each individual record, checking what e-learning colleagues have completed, and then manually updating the ESR system. So here's what we did. We took advantage of the new technology Office 365 that was implemented across the organisation due to COVID-19. We used Microsoft Forms. There are 11 core mandatory subjects. We chose to do a pilot with one module, health and safety. We did the pilot over a 2-month period and we noticed a 4% increase in compliance. We did this by sending links directly to staff to be able to complete these modules on a mobile phone, an iPad, a laptop or any device really. We couldn't have done that without the help from the Workforce Intelligence team, who provided us with the data from ESR with the emails to enable us to send the links directly to colleagues. Due to the success of this pilot, we decided to continue with the rest of the modules. Even though we started off this project, we knew that we would still make further improvements going along. So we improved the way that we send the information to colleagues. Initially, the information was sent separately on a PDF document. This was proving difficult for some colleagues, so we incorporated the knowledge all in one Microsoft Office form. The emails were sent out weekly to remind staff to complete their mandatory training. We now send personalised emails that details expiry dates and links directly to forms. This new approach allows the focus on the retention of knowledge, which means that colleagues refreshing their mandatory training are not required to spend a disproportionate amount of time completing the training. Evidence suggests that learners retaining knowledge is enhanced by short repeated skills training. In turn, this increases the time the colleagues have to care. From the success of the mandatory training forms, we have now gone on to complete and send links to our virtual induction. The most improved single module of all the 11 modules on Microsoft Office forms was Infection Prevention and Control Level 2. This form was initially sent out in November 2020, and from then until the end of May, we saw a 12% increase in compliance. There have been over 10,000 forms completed since we started this process. We've made a real positive impact on the overall training compliance, and we are above now the trust trajectory of 90%. Staff are definitely more engaged in this process. We've received some really positive feedback from our colleagues via emails and telephone calls, and it's good that they've taken time to do this. We have been sharing our successes of this project and working collaboratively with other NHS organisations who have now tried and tested the process and intend on implementing this into their organisation.
Hi, my name is Sita and I'm here with my colleagues Dr. Desai on behalf of the Department of General Surgery for our project on the introduction of care of elderly review for patients admitted with traumatic brain injury to Walsall Manor Hospital. As a background, we know that head injury is the commonest cause of death for young people between the age of 1 to 40 years old. 1.4 million people present to the emergency department each year with traumatic brain injuries, and about 0.2% of these patients die within the first 72 hours. We know from previous studies that actually majority of these cohort of patients are over 65-year-old and presented following a fall. For Manor Hospital, these patients are admitted under the general surgery team for generally for 48 hours for observations. We take inspiration from the autogeriatric care models for patients who are admitted with a NOV as an inspiration for our interventions. For our aim, we aim to standardize the management for patients with traumatic brain injuries and improve early recognitions of signs of secondary brain injuries, as well as reduce the delay in discharge. We base our projects on the PDSA cycle as demonstrated to the right, and we laid out our aims and primary and secondary drivers on the driver diagrams down below. For our methods, we retrospectively collected data for 17-month period in our first cycle from 1st of January 2019 to 15th of May 2020. Following the implementations of our interventions, we collect data prospectively from 1st of June 2020 to December 2020. And these interventions include care of elderly reviews for patients over 65-year-old within the first 48 hours of admission, teaching sessions and posters for the management of traumatic brain injuries, as well as recognizing signs of secondary brain injuries. And these are the example of our interventions. So the first one to the left is our poster that was put up on the board. In the middle, that's the handouts that we're giving during our teaching sessions. Based on what we've done during the teaching sessions, we asked for the feedback from the staff on the ward, and there generally seems to be improvement in confidence or management of the patients, as well as recognizing signs of deterioration.
During the project, we wanted to ensure that the patient population remained consistent, especially in the backdrop of the COVID-19 pandemic, and we found that the age demographic remained fairly consistent, as shown on the pie chart on the left, pre and post intervention. One thing that was apparent from the data was that large amount of delays in discharge were due to the complexity of patients' comorbidities. Most notable was the issue of anticoagulation, which was found to have a high mortality associated, as is evident from the bar chart, something which is echoed by the sentiments of national data. Through this, we were inspired to have the elderly care approach in the pro forma design, and this as our main intervention was found to reduce the length of stay in terms of making it more consistent. We found that the median length of stay remained the same at 3 days, however the range was significantly reduced, as is shown on the bar charts on the left, which showed the length of stay in days graded against the admission GCS. This is reinforced by the run chart on this slide, where the red arrow shows the point at which the intervention was introduced. We found a significant reduction in the patient's length of stays across the board, and no patient stayed beyond 11 days, which was a significant improvement compared to the courses prior to this. Another finding we observed was a significant reduction in the secondary causes of death. Prior to the intervention, we found that 5 out of 9 instances, patients passed away due to an extension of the head injury 48 hours after admission. A further 4 died from issues of secondary infection and sepsis. From our interventions, we had a reduction down to 1 patient dying from an extension of their head injury and no deaths from any kind of infection. Overall, we found that the simple low-cost interventions were able to bring about a significant change and foster an MDT-supported approach to optimize patient care. Translating these into financial costings, we found that prior to the interventions, there was a cost of £107,000 per annum for TBI patients, which was brought down to £51,000 following the interventions. And this was reinforced by the total bed occupancy changing from a value of 412 dropping down to 196 per year. Overall, we feel these changes were quite effective in bringing about quite significant change and would do well as a focused run-up in standard operating procedures of care, something which is being evaluated. These are references, and thank you very much.
Hello, my name is Jon Wilks. I'm the Chief Executive of the Institute of Health and Social Care Management, and all of you at Walsall Healthcare can automatically enrol as members without personal cost to you. Today, I want to talk to you about the importance of leadership in boosting improvement. And really, it comes down for me to a state of mind. It's about understanding what the real objective methodology of leadership is. You see, too long I've heard of stories of TDI, tell, direct, instruct, a kind of a hierarchical approach to leading people and kidding ourselves that it's an effective means of getting consistent high performance from them. I don't think anything could be further from the truth. I've personally been led in a TDI, tell, direct, instruct manner, and it's okay for a period of time. You kind of put up with it, but it quickly runs out of steam. We quickly approach the point where we think to ourselves, this is just all I'm going to do. I'm going to go to the limit of what I'm told to do, and that'll be that. I don't need to do any more than that because that's what I'm being asked to do. I think if we're really enlightened about leadership, then our real role as leaders is to support, encourage, and develop. And that means an absolute understanding that this isn't about negative deviance, it's about positive deviance. And you might well be wondering, well, what's the difference between negative deviance and positive deviance? Why is Jon even talking about this in relation to high performance leadership? Well, negative deviance is really about the whole business of setting people tasks or objectives and then measuring their success or otherwise through fault finding. It's the means by which, unfortunately, too much of our health and social care activity is assessed through inspection, and the inspection's purpose is to find fault and therefore put in place rectification plans of one sort or another. Unfortunately, it doesn't work as a methodology. It doesn't really inspire people. It doesn't enthuse, it doesn't energize and oxygenate. Rather, as soon as we move into negative deviance, tell, direct, instruct, it typically forces things into reverse. It makes people fearful, intimidated, and frightened of consequence. In other words, what do they stop doing? They stop thinking about the art of the possible. They stop thinking about best practice. They stop thinking about excellence, and instead they're thinking about passing a particular assessment or appraisal or inspection. Now, I think we're better than that, particularly at Walsall Healthcare. So I think if we understand that our role as high performance leaders is to support, encourage and develop, then we quickly understand that positive deviance is where we need to be. And positive deviance is all about finding brilliance and then copying it, adopting it, embracing it, making sure that when we understand what great looks like, we feel empowered to go off and work with ourselves and our teams to make sure that we can do it as well. That's a big difference, and it takes a change in here to stop doing the negative deviance activity in terms of leadership and instead start finding great things to recognize, acknowledge and celebrate with our people. And you'll find that as soon as you start to do that, you change the atmosphere, you change the environment, you change the whole reason that people will start to come to work and want to do their very best. They do it because they're enjoying the process of actually being great at what they do. They do it because they believe in you and they believe in the high performance environment that you enable and create. I hope that's all clear. I didn't want to say too much on the subject, but I was very delighted to contribute to your leadership development activity, and they're my thoughts on the importance of leadership in boosting improvement. Just remember, as a final thing, it's not about you and them, it's about how we serve our patients and their families. And if we start from the patient and work backwards whilst applying this positive deviance approach, support, encourage, develop, I promise you, we are on the right track. Bye-bye.
Hello, today we're going to be talking about the pilot training on early onset sepsis risk tool for neonatal and midwifery teams. And we're going to focus on improving the efficiency. This has been conducted by Veronica Sabo and Sanur and has been helped with Hesham Abdalla and Pooja Siddhi, as well as the Walsall Healthcare Trust.
So a little bit of background. Early onset neonatal sepsis is a rare but life-threatening condition that can occur in a newborn's first days of life. Currently, most hospitals in the UK use NICE guidelines to determine whether or not to give a newborn antibiotics, but this results in overprescribing, which can have adverse effects later in the child's life. Recently, an American company, Kaiser Permanente, have developed a new online tool for this called the Sepsis Risk Calculator, or SRC for short. Using this tool compared to NICE guidelines results in 74% reduction in early antibiotic usage and a 50% reduction in inpatient hospital days. And the SRC is going to be implemented in use into Walsall Manor Hospital next month, but we didn't really know how aware of this the healthcare teams were or how prepared they were to start using the SRC. So this is where our project comes in. We created an online training program about what the SRC is and how to use it, and then tested it on healthcare professionals in the hospital to see how they responded to it. And then based on their responses, we made changes to the training program to be more effective as we plan to keep using it in the future. The training module was created using Powtoons and an online voiceover video containing case studies. And we also created before and after questionnaires to get people's opinions on it. This was then sent out to healthcare professionals in the hospital who work with neonates.
So going through the results, we see that there have been 31 healthcare professionals that were recruited for this task. And we've got a wide variety of individuals, including doctors and other healthcare professionals, with the other healthcare professionals being midwives being the most of them. We collected this data between the 19th of February and 11th of March, and because of this, we managed to get a good amount of data. So most staff were unaware and untrained. They found that 58% were aware of the tool, and in terms of prior training, 74% said they had none. However, 96% did say that SRC is needed, and 96% also are happy for this to be implemented. However, they were not aware that NICE were advocating for the SRC, with 51.6% not being aware of this. In terms of after the training, they found that the training program itself was clear, with 88% saying the module was clear in and of itself. In terms of the access difficulties, it wasn't difficult for them at all. And when we try to quantify in terms of the self-reflection of themselves to see what rating they would give themselves in terms of how comfortable they were getting to use that tool, they found they were a lot more comfortable after the training, with more scoring 4s and 5s rather than 1s and 3s. Key recommendations were given by the staff, which were quite valuable to us. We found that face-to-face training was still suggested even after the implementation of online training induction. However, due to COVID restrictions, this has obviously not been something that was plausible. However, given the second point of having an interactive session is still plausible using a Zoom as such. More details on the initial midwife assessment regarding to the use of SRC forms has been suggested, and that can be easily implemented into the online training program. And more clarification is required on how the early onset neonatal sepsis score correlates with the category of care given.
So our conclusions from our study, we found that the training tool was overall effective. It enhanced the awareness of the SRC within healthcare teams, and those who participated were very willing to change their practice to accommodate it. Before the training, the staff marked that on average they weren't very comfortable using the tool, and then after training they were significantly more comfortable using it. And alongside that, they also provide very valuable feedback on how to improve the tool for future use, such as restructuring the training and refocusing what it places importance on, which is something that we will take on board when making it in the future. So that has been our presentation. Thank you very much for watching.
Video calling, patients staying in contact. The project. The coronavirus pandemic has had a huge impact on the NHS and has resulted in organisations needing to find new ways of working to ensure services are still being delivered to a high standard. The COVID-19 restrictions led to all hospitals needing to stop visiting. This resulted in patients not being able to have in-person contact with their loved ones. This is when video calling service was introduced, supporting our patients who couldn't use or didn't have access to their own devices. The service was trialled in April 2020 with the intention of continuing if successful. The service had support from redeployed staff, medical students and volunteers, with the overall management sitting with the patient experience team. The service allowed us to carry out over 1,000 calls between patients and their loved ones, including international calls. Calls were also made from ICU to help bring comfort to families at such difficult and worrying times, including a call to a patient who was at the end of their life. We were able to support the family who were unable to come in and say their goodbyes. The service touched the hearts of many families, patients and staff during restricted visiting in the hospital, and we thank everyone who was involved in it. The achievement. Since starting the calls in April 2020, our validated figures show that in total we carried out 2,600 calls from April 2020 to May 21, with our busiest period being May 2020 to August 2020, with 2,244 calls taking place. From April 2020 to September 2020, we had continued support from redeployed staff, medical students and volunteers, enabling a 7-day-a-week service. We were able to proactively visit wards to ask patients if they would like a video call with their friend or family. From September 2020 to May 21, the service was solely run by the patient experience team, with limited support from volunteers. This resulted in us asking the relatives to call the team to arrange a video call booking time and reduce the service to 5 days a week. However, as a team, we still communicated with the wards continuously and outlined the process of video calling to ensure both relatives and patients were given the opportunity to use the service, and it still remained popular service right up until visiting was reintroduced. The importance of visitors to patients. Visitors play an important part in the recovery of a patient while in hospital. Being in hospital can be daunting for many, and being able to see a loved one whilst being an inpatient can have a positive impact on the mental well-being of both patient and relative. When visiting was stopped, we knew we needed to support both the patients and their families to ensure they could still communicate. To illustrate the importance of visitors, we have collected quotes from patients who received visitors in the first week of the hospital allowing them back on site. Take a moment to read some of the comments below. The legacy. On many occasions, both patients and families expressed their gratitude for the video calling service they received. We often saw an instant improvement in patients' well-being when carrying out the calls with their loved ones. On one occasion, we supported a patient to speak with her grandchildren. One of them lived in Singapore, whilst the other was in Algeria. The patient was really happy when we approached her and asked if she wanted to see them and speak to them, especially the granddaughter, as she was pregnant and expecting the child in a matter of weeks. As a team, we have been gifted chocolates and thank you notes from both families and medical students who supported us through the busiest months of the calls. The medical students who supported us expressed their appreciation for the opportunity to support us and said how it provided them a different experience of the hospital and allowed them to put themselves in the shoes of patients and relatives. Below is a thank you note from Holly, a medical student, and it reads, "Dear Purple Hub, thank you for this opportunity to help out over the past few months. I've really enjoyed it and have loved seeing patients enjoy the video calls too. I am sad to say goodbye and will miss you. I wish you all the best for the future. You do a fantastic job. Take care. Lots of love, Holly." The legacy. The video calling service will continue within the organisation beyond the COVID-19 pandemic and once visiting is fully reintroduced. If someone is unable to visit, or if a relative is international and wishes to speak to a patient, we will do our utmost to carry out this call virtually. The experience of patients is important to us, and this service allows us to provide something special to both the patient and the loved one. And we are Walsall and proud and are able to deliver such a service. Thank you for watching.
Lung Cancer Quality Improvement Project. Hi, I'm Dr. Abraham, the Respiratory and Lung Cancer Lead here at Walsall Healthcare NHS Trust. I would like to start by dedicating this project to Paul, whom his legacy was the ignition of this 2 years project. I came across Paul 2 weeks after I joined Walsall Manor as a respiratory consultant. The outcome of his care was not what anyone would want it to experience, and for that reason myself and my colleagues in the trust took the initiatives to transform the lung cancer service here at Walsall. This project was led by the respiratory team with a steering from Medical Directorate in collaboration with other local NHS hospitals. The main aim of this project is to achieve the lung cancer optimum pathway and to provide a quality care to our lung cancer patients. Here I would like to hand over to Jane Powell, our lung cancer specialist nurse.
Hello. I would like firstly to pick out just 5 points of our improvements that have been made. The aim of this is to provide safe and high quality care, and I'd like to first talk about patients seen timely. We have implemented a new rapid access service. We have empowered GPs to have access to requesting CT scans. The CT scans, those reported with malignancy, are then triaged through the rapid access service triage group, and those patients with malignancy reported on their CT scan receive appointment within 7 days of the CT scan being reported. Secondly, we looked at staffing and safe staffing levels. Formation of a business case to strengthen the respiratory workforce has now been approved, and we are currently recruiting additional CNSs to the team, lung cancer support nurses, and also additional pleural nurse. In addition to this, we have recruited a lung cancer navigator to enhance the patient's cancer journey and also to support patients throughout that journey, and also a lung nodule tracker who tracks nodules on nodule surveillance and upgrades those patients to a cancer pathway when there's a suspicion of an early malignancy reported on their surveillance CT scans. We've established a twice weekly cancer tracking PTL. That's a team PTL and the Trust Cancer PTL to review all patients that are currently on a cancer pathway and to identify any potential problems in that pathway. To ensure that we have been making the right improvements, we thought patient feedback would be important. So for this, Lynn Waldron, our lead cancer nurse, oversaw a patient satisfaction survey. This was to gather their experience throughout their cancer journey and also to have some feedback on what they felt we needed to improve on. This helped to standardise our internal and external referral pathways. And it also improved our 2-week wait performance. 100% of patients are now seen within the 14 days. I'd like to share now some of the patient comments for the team. Thank you.
Hi, I'm Fred. I'm one of the F2s here at Walsall. Thank you for the opportunity to talk about our quality improvement project. The aim of our project was to improve diagnosis and management of iron deficiency anemia, specifically in patients attending for surgical resection for colorectal malignancy. From the evidence, we know pre-op anemia is associated with poorer outcomes following surgery, including higher incidence of complications such as an anastomotic leak. Ultimately, our aim was to embed a standard operating policy into clinical practice at Walsall to achieve sustainability of this project and to help improve patient outcomes. We followed a PDSA cycle and collected data from 137 patients over an 18-month period from June 2019 to November 2020. Following an intervention in October 2019, we then prospectively collected data relating to diagnosis and the subsequent management of iron deficiency anemia. So an interventional educational evening surrounding management of preoperative iron deficiency anemia was attended by a multidisciplinary team, including surgeons, anaesthetists, pre-op nurses, blood transfusion practitioners and colorectal CNS team. Following this event in October 2019, there was an agreement to treat iron deficiency anemia by medical day case. We diagnosed iron deficiency anemia in keeping with the recent international consensus statement on perioperative management of IDA shown here. Both females and males with hemoglobins of less than 130 grams per litre were treated as anemic. A ferritin of less than 30 confirmed IDA. Patients with ferritin above 100 were excluded as having anemia of chronic disease. Here is the paper we used to define the diagnosis of iron deficiency anemia. We aligned our management with NICE Guideline 24 on blood transfusion, which recommends the use of IV iron as therapy for patients diagnosed with iron deficiency anemia if the interval between the diagnosis of anemia and surgery is predicted to be too short for oral iron to be effective. Our QIP also aligned with the 2021 Commissioning for Quality and Innovation, or CQUIN framework, shown here. This is aimed at improving patient safety by screening and treating iron deficiency anemia. So there are financial benefits to this project also. So here are two run charts with our final data shown. The chart on the left demonstrates an improvement in iron deficiency anemia diagnosis following intervention in October 2019, and the chart on the right shows an improvement in referral for IV iron therapy. So the average percentage of patients with their ferritins checked improved from 31% to 58% following our intervention in 2019. We also saw an improvement in management. So before intervention in 2019, 0% of patients had documentation that they were referred and treated for IV iron, whereas after the intervention, we found evidence 11 of the 24 patients with iron deficiency anemia there was documentation they had been referred for treatment with IV iron. Our results also showed a reduction in post-operative blood transfusion from 0.85 units per patient on average to 0.66 units per patient following intervention in October 2019. In conclusion, we found a clear improvement with both diagnosis and management of iron deficiency anemia, with still work to be done. Operating policy is currently being developed to standardise the assessment, the diagnosis and management of preoperative iron deficiency anemia here at Walsall Hospital. And with our reduction in post-op blood transfusion resulting in lower costs, we hope to continue and achieve sustainability of this project.
Hi, my name is Heidi Worley and I'm a Band 7 physio working in the Cannock Community Stroke team. I'm presenting our QI poster. Our QI poster was based around the design and implementation of YouTube videos to support home rehabilitation in stroke survivors. Briefly, our service is a stroke specialist role in which we, on initial assessment, we identify the specialist therapies that are required for patients' individual rehab needs. We'll discuss the realistic goals and discuss the frequency of therapy that's required depending on their individual needs, reviewing goals at 6 weeks and progress at regular intervals from their initial assessments with physios, OTs, speech and language therapists and stroke nurses that are involved in their care. To achieve the desired outcomes and goals, this requires the patients to have an intensive exercise regime, which involves patients engaging in home exercise programs from all our therapies. Providing a home exercise program to patients is one of the most important aspects of therapy. Patients who comply to their prescribed exercises are significantly better at achieving their goals and demonstrating a greater increase in physical function. Compliance to home exercise programs can be affected by memory, pain, psychological symptoms. Commitment to a home exercise program is also a significant issue. Visual aids can be more beneficial for patients in understanding the exercises and remembering the exercises once we've left the property. As you can see here, the demonstration picture to the visual picture shows such a difference in how you'd understand that exercise. During the pandemic, we were faced with new challenges of trying to continue to provide therapies and achieve goals for patients, but in a safer way. So we explored the use of videos. Telerehabilitation refers to providing rehab services using electronic communications technology. There was 2 studies that were done, and this one study found that telerehabilitation was just as effective as in the clinic rehab. And another journal found that the research concluded that telerehabilitation is a useful approach during the pandemic. So we selected the commonly used exercise sheets that we use for our patients and we recorded them in our therapy gym area. We then contacted the communications team, and they set up us a private YouTube channel that was only accessible through the web link. We then included the narrative of the exercises, and the filming was completed over a week. Video editing and uploading took about a day. After using our YouTube videos, we sent some questionnaires to the staff. So we gave out the videos to our patients, and then we questioned our staff on the age of the patients that they gave the exercises and the videos to, the clinical reasoning behind why they gave the videos and not the exercise sheets, the usefulness of the videos, would the therapist continue to use the videos as a rehab tool, and the limitations that they found with the use of the videos. So the results from this just show that the main reason for giving out the exercises was the visual side of things, to improve patients' visual ability to see the exercises, which seemed to give the patients a little bit more motivation, and to decrease our face-to-face contact, so that they'd have the exercises to feel a bit more motivated to do their exercises. We also found that the limitations the therapists found with the videos were that they need a leaflet to go with the links, they forget what videos we have for exercises, the patient's access to technology and YouTube was one of the biggest limitations, more exercises were needed, forgetting to use them, and patients needing to be motivated, and also not having access to links during the appointments. So on reflection from this feedback we received from the therapist, the learning points have been made are to reflect on and develop this rehabilitation tool, to create some patient feedback questionnaires to find out what the patients think of the videos, some more variety of videos, an information leaflet, and to use a MECOS setting as a way of auditing the goals that have been achieved by patients using the rehab videos compared to paper exercises. So we can conclude from this that we have found that using YouTube videos as a rehab tool has helped the team to be more effective with their time, reduce travel time and unnecessary mileage, encourage patients to be independent with their rehab, and help protect patients from unnecessary face-to-face contact during the COVID pandemic. Thank you for watching.
Hello, my name's Stephanie Reid and I'm the Head of Improvement Methodology and Delivery at NHS England and NHS Improvement, and I'm absolutely thrilled to be with you, albeit virtually, at your QI Awards ceremony in Walsall Healthcare. It's a real thrill to be invited to be part of the event, so thank you for that invitation. I've had the enormous privilege of looking at your poster wall, all 73 entries, and a few things struck me. One of which was that you are real evidence that you know, huge and amazing changes and improvements don't need to be cajoled or coerced. We just need to unleash wonderful people to do wonderful things. And the other thing that really struck me about the poster wall was the range and the scale of the work that you guys are involved in, and the extent to which that really relies on a crucial part of improvement, and that's teamwork. It's something I'm really passionate about, and you exemplify it enormously. Looking at your entries, nearly all of them are from more than one person. Most of them involve two or more people. And even those that are from single individuals will always involve a team in implementing them. And that's a really important part about improvement, that the importance of teamwork. And I think there are two real reasons why teamwork is important in improvement to make it really, really effective. And let me try and show you what I mean by them. The first of those reasons is about the fact that each of us brings a unique perspective, and that's really important. Let me try and illustrate why. I am going to show you a short film. It's not about healthcare, but I think you'll like it. And what I'd like you to do as we go through the film is see how many changes you can spot. You'll see what I mean when we start the film. Okay, get ready. Here we go.
Clearly, somebody in this room murdered Lord Smythe, who, at precisely 3:34 this afternoon, was brutally bludgeoned to death with a blunt instrument. I want each of you to tell me your whereabouts at precisely the time that this dastardly deed took place.
I was polishing the brass in the master bedroom.
He was buttering his haunted stones below stairs, son.
I was marking my petunias in the rocking shed.
Constable, arrest Lady Smythe. But how did you know? Madam, as any horticulturist will tell you, one does not plant petunias until May is out.
So, how many changes did you spot? 4, 5? That's usually the number that most of us get first time round that we watch this film. Occasionally you get a really, really observant person who might spot 8 or something like that, but it's usually 4 or 5. How many did you get? Let's have another look.
It's just a matter of observation. Lucas, how observant were you? Clearly, somebody in this room murdered Lord Smythe, who, at precisely 3:34 this afternoon, was brutally bludgeoned to death with a blunt instrument. I want each of you to tell me your whereabouts and precisely the time that this dastardly deed took place.
I was polishing the brass in the master bedroom.
I was buttering his haunted stones below stairs.
I was marking my petunias in the rocking shed.
Constable, arrest Lady Smythe.
Okay. Hopefully that was a little bit of fun, but you enjoyed it as well. And here's the thing. Most of us spot 4 or 5 changes, but when you compare the changes that you spotted with someone else around you, what you tend to find is they spotted things that you didn't spot and vice versa. So here's the thing about all of us. We all have our own perspectives, usually the result of, you know, our background, our education, all kinds of things add to that richness of perspective, but it's our individual perspective. each of our perspectives is different, and it's easy to miss the stuff that you're not looking for because you're not aware of it. Each of us has got a piece of the jigsaw puzzle, but none of us have got all of the pieces of the jigsaw puzzle. But if we combine our perspectives, we're far more likely to have a greater view of the whole picture. And that's what we really need in improvement. We need that richness, we need that colour and vibrancy of the picture of what we're looking at and what we're trying to achieve in order to do it full justice. So those different perspectives are important, and everybody's voice and everybody's perspective is equally important in pulling together that whole picture. And that for me is one of the key reasons why teamwork is vital to improvement. That kind of leads me on to my next point as well, which is about improvement and learning, because all improvement involves learning. Unless you learn, you're not going to improve. And when we think about improvement, one of the definitions of quality improvement that is often used is this one on the left-hand side of the screen here, which is about using systematic change methods and strategies to support incremental improvement, to change behaviours and organisations, so to change how we work as well as what we do and how we organise ourselves, in order to achieve better outcomes and better experience for patients and staff. Now, the key thing about those systematic change methods and strategies is that all those things are learning tools. They're tools to help us learn about what our challenges that we're facing, tools to help us think about our aim and how to articulate our aim and what we're trying to achieve, tools to help us learn about things we might try doing that might improve things, tools to help us think about how we can test those ideas, and tools to help us measure what happens when we apply those ideas. Did it actually result in an improvement or not? That's all they are, learning tools. There's also something about the importance of reflection in action and on action. So learning from when we're doing something, when we're taking action, as well as after a course of action or after an event. Think about how you can build that learning into your everyday activities. Think about things like handovers and huddles on a daily basis. Really important sources of learning and really important sources of sharing perspectives. As well as the reflection after a course of action or after something has happened. How do we get together and how do we share what we learned, and how do we take that forward to make sure that we build that learning into the next activity that we're taking. Things like after action reviews can be really, really vital. But the thing about all of those activities to learn is that it's most effective when it's shared. Because if all we do is we reflect on our own action, we're perpetuating that same perspective, that individual and own perspective, rather than enriching it and enhancing it by sharing perspectives with other people. And the other thing that we tend to do when we're learning from action is we tend to focus on things that didn't go quite so well as we'd hoped, or things that didn't go according to plan. And that's really, really useful. But don't miss the opportunity to think about the 99.999% of the time when things did go according to plan. What can you learn about what were the common factors that were in place when things really did go well and when things were reliably working well? What can we learn from that? On the right-hand side of the screen here, you'll see there's a reference to a research study about University in Wisconsin, where they looked at sporting teams and compared the team's performance for those that were coached using just videos of the failures and those that were coached using videos of their successes as well as their failures. Those that used both methods of learning were the ones who improved most. So it's really important to do that too. And finally, the importance of events like today. Social connection and discussion is 14 times more effective in spreading good practice, new knowledge, much more effective than the written word, than sending out a report or just an email or a note to somebody. So this is really important, and hopefully it's a joyous occasion when you can get together and celebrate the great stuff that you've done. So, from me then, huge congratulations to everybody concerned. What a fantastic event, what an amazing group of people, and what a wonderful cause to celebrate. So have a great rest of the evening. Thank you for inviting me, and best of luck in the awards. Bye.
Hello everybody, thank you for inviting me to talk about our improvement journey in ED. My name is Ms. Joshi, I'm the Clinical Director for Emergency Services. Just to put it in context, through the COVID period and post-COVID, the department was struggling to provide safe, effective, responsive care. The performance had deteriorated around some of the key metrics, and this had led to increase in patient safety incidents, poor patient experience, and extremely poor staff morale. This led to a culture in the department where there was tolerance to poor standards of care, and overall there was an overwhelming sense of COVID fatigue. So as team of three, with ED matron and the care group manager, we discussed the state of the department amongst ourselves and also with the divisional team and with the chief operating officer. And the decision was made to plan a perfect week and try and change things in the department. There were two main aspects to the perfect week. One was, which was the main one, is that staff bring their perfect selves to work, i.e. look at what their roles are, what their responsibilities are, and ensure that whilst they're in the department, they give it 100%. The second aspect of the perfect week was, as leadership team, we looked at the barriers that contributed most to poor patient care and prognosis and process within the department, and we tried to work through some of the key issues. The concept of being perfect. So this was important. It was really important that we put to our staff and make them understand what we thought as the concept of being perfect was. Which was around, as I said earlier, bringing their selves 100% to work. Whilst the staff were thinking that the perfect week would mean that they would have more staff on the shop floor, there would be no exit flow barriers, there would be no overcrowding. However, we quickly pointed out to them our concept of perfect and our expectation of them. It did take some time for them to understand the concept, but when they reflected on the concept, they realized that by not focusing on what others aren't doing or processes that aren't working, they were able to do their work with positivity and with energy. This empowered them, and they realized that they were able to make a difference in their patient's journey. We involved our key stakeholders such as bed flow, ambulatory care, AMU, surgical assessment unit, pediatric assessment unit, and radiology department, along with the urgent treatment center. We discussed some processes of communication to reduce to and fro of patients and reduce some of the frustrations that each clinical member were experiencing. And this improved efficiencies around patient management. We also provided some practical support to the department in the form of increased presence of the leadership team, especially out of hours. We looked at our nursing and medical rotas and ensured that we managed them as best as possible. We did introduce a 24-hour progress chaser patient tracker in the department, and our matron introduced the concept of a band 7 helicopter role nurse. This person had a 360-degree awareness of the entire department and was able to act on any problems that were experienced. The result of the perfect week was tremendous. We saw a can-do attitude within the team. There was a sense of positivity and empowered mindset between the team members. There was a sense of self-belief and confidence in delivering the expected standards of care and supporting each other. This resulted in further distributive leadership within the department alongside accountability and a sense of ownership and responsibility. This then led to improvement in all aspects of performance, and we saw a step change in culture within the department, and we had a new way of doing things in the department. The staff asked us to continue the perfect week to the perfect month, and our journey continues. I'll talk about some of the slides which depict our improvement. So the first slide is our national ranking within the country within 113 trusts. So we were 14th in March, and then 19th, 17th, and currently we are 8th nationally. We've never ever achieved that status. And in terms of our performance within the West Midlands, we again improved our performance and our standing, and we are currently 3rd. We were always good in ambulance handovers, but in the last few months we have been consistently good and 1st in the region. So 97% of our ambulances are handed over within 30 minutes, and we are 1st in the region for this. As you can see, this is our 4-hour performance in the last 12 months, and again since March, and there's been a distinctive change. We obviously reduced in our performance and deteriorated significantly during the COVID period, but then we've picked up now. Our patient assessment within the first 15 minutes, so we are consistently good and ensuring that all our patients get assessed within the first 15 minutes, and this is an extremely important qualitative measure. And again, our ambulance handover within 13 minutes is consistent and is within the standard that is expected. This slide is very interesting because it shows the average time that a non-admitted patient spends in ED, and as you can see, we have made main gains in this, and the hours that a patient spends in ED waiting without any treatment has reduced significantly. Journey ahead, we still have a long way to go and a lot more to achieve. We do want to work more on collaborative working, creating a little bit of resilience in the team and innovation. As a team, we would like to see the whole umbrella of urgent and emergency care pathway under one roof, starting from the UTC through to ED and leading up to the same day emergency care, this being a seamless journey. This will provide some collaboration and resilience within the teams and a sense of joint ownership of patients on the urgent and emergency care pathway. Thank you very much.
Hello, my name is Anne-Marie Cannaby. I'm the Interim Deputy Chief Executive and Chief Nurse. This evening I'm presenting the winners of the oral presentation. We had 73 posters and 12 of the poster submissions were asked to do an oral presentation. These are the results. The 3rd place for the postnatal contraception on the maternity ward by Tanya Granger and the sexual health team. The 2nd place was the diagnosis and management of iron deficiency anemia, that is Fred Wynne Griffiths and the multidisciplinary team. The 1st place is the Opiate Appropriate by Maria Eleni Ziplus and the orthopaedic team.
Hi, my name's Ned Hobbs, Chief Operating Officer, and I'm delighted to be announcing the 5 posters that fall into our highly commended category. We received 73 poster submissions, 12 of which were formally presented, and the following 5 have equally been scored as highly commended. They include improving the clarity of frailty discharge information, and a big thanks to Dr. Elizabeth Bentley. Increasing student placement capacity through the CLIP model, and well done to Lorna Kelly and all the team. The Oxygen October programme, and a big well done to Catherine Firmstone and everyone involved with that. Our QI project registry itself, well done to Tom Johnson, Rich Pearson and the rest of the team. And our COVID pandemic maintaining regional anaesthesia teaching for trainees, and a big well done to Sarah Birch and the team for that one. And in addition to the judged posters, there are 2 further awards which I'm very pleased to announce. Both the poster which has had the most views and our People's Choice Award winner, the poster that has received the most votes. So firstly, our poster with the most views for it is Oral Comfort at the End of Life. Well done to Lizzie Walters-Mabbott, Pippa Pinches and Sajid Basra and all the team that have contributed to that excellent programme of work. And the People's Choice Award winner for our most voted poster goes to the Integrated Front Door Service, and a huge well done to Kirsty Donaldson, to Kerry Sansara and to Linda Roberts for that piece of work.
Hello everybody. I take this unique opportunity to share my feelings and association with Steph Clarke. I knew her personally, and being an education supervisor and mentor, I had a long association with her while she was at Manor Hospital. She worked with us during August 2017 and 18. She was not only a good clinician, but a wonderful person, affectionate, caring, kind and compassionate human being. The way she used to deal with her patients and peers was absolutely wonderful, and I'm sure everybody who has worked with her can vouch for that. While she was planning her medical career, life had different plans, and unfortunately she was diagnosed with a mesenchymal chondrosarcoma. Though she responded initially, but the disease recurred in September 2018 and took her away from us at Manor Hospital. It was a very sad moment for all of us. We still remember her very fondly. She touched all of us who knew her, and we hope that yearly award will be held to keep her in memory and her values alive. Both the recipients of the award so far have been delighted and honored to be recognized in this way. And the year group has wholeheartedly really appreciated recognition that this award brings to them. Each year, in memory of Steph, we award a foundation year doctor with FY2 of the year award. We are looking for a doctor who best demonstrates Steph's values of holistic care of the patient, support for the team members, thirst of knowledge and development, and ability to go above and beyond the call of duty to provide the necessary care for her patients. Your nominations were expression of appreciation, gratitude for a cohort of colleagues who have thought extraordinary trials have been pushed to deliver services well beyond what anyone could have expected. Some junior colleagues have long COVID, others have had mental health significantly affected. All have gone beyond the call of duty to provide the best care for the patients. All the best to all the nominees, and I'm sure the panel member would have decided the best outcome and they picked the best one for this award for this year. I also take this opportunity to declare that third time in a row, Dr. Aidan Plant has been selected as the best trainee. This is a hat-trick for him. His contribution and his mentorship and pastoral role has been absolutely brilliant. We also have decided to give runner-up awards for 3 of our supervisors: Dr. Rumi Jamdali, cardiology consultant; Dr. Jayant Gupta, cardiology consultant; and Dr. Ruchi Joshi, A&E consultant. Congratulations to all the winners. Thank you very much.
Matthew Lewis, I'm the medical director. I'm delighted to be presenting the Steph Clarke FY2 Doctor of the Year award. Having known Steph Clarke when she was working in the trust, I'm sure she'd be absolutely delighted to see so many nominations. In fact, there were 20 people nominated by colleagues for this award. I'll go through their names for you, and apologies in advance if I say the name slightly wrong. So the nominations are Frederick Wynne Griffiths, Sita Checha Benayaka, Nimai Desai, Imogen Heaton, Amy Berry, James Roberts, Elizabeth Bentley, Rosie Elsgood, Imogen Prasad Jackson, Samin Suhail, Anjali Kumar, Laura Boyd, Umar Nawaz, Trish Ang, James Downs, Maria Ziopos, Emily Pegg, Nikita Kiwani, Amanpreet Kalu, Tahira Khan. All of you can be really proud of the fact you've been nominated for this award. We have 3 runners-up and 1 winner. The comments on the runners-up. The first one, she is a team player. She is kind and warm and treats her patients with the utmost respect. She has excellent communication skills and always strives to do her best. Above all, she is always a ray of sunshine to work with. That is Trish Ang. Well done. Second runner-up, she is a kind and conscientious doctor who can be relied upon to complete tasks even without being asked. We were redeployed together and she was always on hand to support as we dealt with the most emotionally challenging situations. That is Rosie Elsgood. Well done. And lastly, very keen to learn, improve and do good for patients, department and hospital. Has shown remarkable leadership qualities, including having the leading role in organising social events during the last year. He's worked very hard to create a sense of community between the FY1s and FY2s. He is very supportive on the wards. That's Fred Wynne Griffiths. Well done. The winner of this prize has an extraordinary 8 nominations from their colleagues, and the following gives an idea of what people have said about him. He is very knowledgeable and handles emergencies well. He always goes the extra mile for his patients and colleagues and is always a calm, level-headed and supportive presence on the ward. He is always keen to discuss and learn from patient cases and reflects on how he could have improved care. On and off the ward, this doctor takes an interest in the well-being of others, whether it be doctor colleagues or other hospital staff. He's helped us massively as a group of F1s when we were first starting out, and genuinely went out of his way to help check on our mental health. He remains a very humble and quietly spoken person, always acting as the patient's advocate and picking up details that might get missed on a busy ward round. He's an excellent colleague and remembers to see the humour in things, even under pressure, and he will always go the extra mile without mentioning it or causing a fuss. I'm delighted to award the Steph Clarke FY of the Year award for 2020 to Nimai Desai. Well done, many congratulations. The first award I'd like to present is the Cost Improvement Award, which goes to Mr. Nazim Warich and the surgery team for their work on traumatic brain injury through the introduction of a dedicated elderly review. Congratulations. Secondly, I'd like to present the Patient Public Participation Award, which goes to the sexual health team for their work on postnatal contraception on the maternity ward. Congratulations. And lastly, I'd like to present the QI Awards for 2021 overall winner. And this award goes to Mr. Thomas Moores and our ACP Louise Pickering for their work on hip fracture, overcoming the challenges of being an outlier. Tremendous piece of work. Many congratulations to all of you.
Sound working? The sound testing? Hi! My name's Thomas Moores, one of the orthopaedic consultants, and I'm here today to accept a very special Quality Improvement Award on behalf of the orthopaedic team. We submitted a project looking at how we've done or what we've been doing to improve our hip fracture care at Walsall, and this has been headed up by myself and our ACP Louise Pickering. So, as I'm sure you're all aware, quality improvement and QI is all about the fishtail, it's all about the driver diagram, and it's all about run plots. So we had so many that I decided that we wouldn't do any for this, except maybe this next one. To give you a bit of a background, so this is our data from the National Hip Fracture Database, and if you go all the way across to the black line on the first third of that graph, you can see that we were doing okay, but then in 2018 we became a national outlier. Our mortality rate rose to 11.8%, and this was unacceptable compared to the national average. At this point we decided to start our quality improvement project, and I'm pleased to say now, even through COVID, we are now tracking the national average for mortality, which is halved at 6.2%. So what was the challenge? Where do you start? Because it was such a massive problem, and because it's a multidisciplinary approach to this, it was more than one single, it was multifaceted, it was complex. There was no one single solution that was going to reverse and change all these things. And I'm not going to show you all of the run charts, the dot plots, the PDSA cycles, the driver diagrams, or even the fishtails, like I said, because that would completely cover the whole of a theatre floor, because we had so many different things that we needed to do. So we needed to look at the problem from different specialty perspectives and then discuss these. So what we started to do was we started to build a team of like-minded individuals that consisted of orthopaedic surgeons, anaesthetists, orthogeriatricians, physiotherapists, nurses, specialist nurses, ACPs, and try and understand the problem. We spent some time gathering data in real time to look at how we were doing, and we identified some real key themes. Themes that we realised were the main problems of helping us achieve best practice tariff and caring for these patients. For instance, our INR reversal for warfarin was not quick enough, so they were missing their theatre slots. We didn't have the consistent orthogeriatric reviews, and therefore it wasn't a true MDT approach to the problem. And we also didn't look at mortality in a very open and honest way. We looked at it very defensive, trying to find out that there were trying to say there were no problems with what we were doing, but actually looking at it with a standardised protocol at every aspect of care, we were able to identify really key areas, and that's helped us to start these projects and see how we can improve. The next thing we decided to do with all of this data was to visit somewhere like us, a DGH with a similar patient demographic, with a similar work ethic, but one that was doing much better than we were. We compiled our team and we took surgeons, anaesthetists, physios, managers, ACP, ward nurses, ward sisters, all over to Rotherham after organising it and telling them the reasons why we wanted to go there, because their mortality rate was around 4.5%. Their best practice tariff was one of the best in the countries at around 70%. So what were they able to achieve differently to us with exactly the same facilities and patients? And I'm from Liverpool, so like all good Scousers, we stole all their good ideas. We asked them what they did. We looked at every aspect of care, and we went through from that patient journey in A&E all the way through to discharge to see how they'd changed things. This then helped us realise how they prioritised patients to make sure that they were seen, that they were on the next day's trauma list ahead of other trauma cases, and if they needed to expand their trauma lists, that's what they would do, but they would always put their hip fractures first. They also sent out weekly reports. Why? Because as orthopaedic surgeons, we all like to compete with each other. So if I could tell you that I'm doing better than someone else, that will motivate one of my colleagues to reprioritise his patients to get those NOF patients done. And we're able to now do all of these things, and we offer weekly feedback to the on-call team to say this is how successful you were. We realised that their physios had to change their working hours in order to see elective and trauma patients and to get them out of bed on day one, because this is one of the most important things. We realised from what they do in recovery that they try and optimize that patient before they get back to the ward. So they had a target of HB of above 100 before they could go to the ward. This meant that they were very likely to be able to get bum off bed and start walking on the next day. And this helped their physios, so instead of having to not be able to mobilise them. And what does mobilising early mean? Well, it means you're less likely to get a chest infection, you're more likely to get home quicker, and therefore they saw their length of stay reduce. But the most important thing was to identify colleagues who wanted to improve the care for our patients, because actually we could steal all these good ideas, but without the right team and the right people involved, this was never going to work. And what we realised from Rotherham and all of our fishtail diagrams, driver diagrams, were that it was actually the small things that made the biggest differences, and being able to make a small consistent change and being able to maintain that would be how we could make a very big change. And each on its own was a massive challenge, and that's why we've got a number of posters and presentations at the QI Awards today, because different individuals have led those projects for the whole wider team. And I'm not going to go into too much detail about them, but because of all those small, now sustainable projects, our standard of care is massively improved. But not only that, we asked every member of this MDT to contribute to say what they think they could bring as a solution to a problem. Everyone then took those projects on, and most importantly, we met regularly as a group to hold each other accountable for what have you done and how have you done it. And instead of doing what maybe other failed projects had done in the past, is we didn't just pay lip service to it. That accountability was the most important part. So how do we change this? How can I help you to change that? Who can I link you with so that we can start the conversation? Is that someone in the community? Let's invite them to our meetings. Let's get the conversation started, because without talking, without being open, without saying this is what we need help with, we wouldn't be able to have progressed the standard of care for our patients. And not only that, when a project was successful, we then learnt from each other to see how we were able to do that. And like I say, it's all about those regular meetings, touching base every 1 to 2 weeks, all of us in the forum together, and then not taking anything for granted, because when we thought we were doing well, we then need to keep on looking at it. What's changed? Why are we going backwards? Why are we now not hitting those targets? And not only that, we all wanted this to be a success, not just for us as a team, but because we then knew we were offering our patients the best standards of care. So what does the future hold? So what I would say is, to date, we're now off the outlier list. We've managed to get our mortality down. We are holding our own with the national average, and some months were even better than that. But it's really about maintaining what we've achieved, and COVID has brought so many problems along with that. For instance, with the second wave of COVID, we had an unacceptably high number of deaths, but they were all COVID related deaths. So We also noticed that the national average went up accordingly with that, so it was obviously not just our centre that couldn't cope with that. We're also now able to say that we've got 2 new ACPs starting, one at year 1, one almost finished, and that will help support Louise in her role in order to help deliver continuity of care throughout the whole year, and also the whole week, so 7 days a week, to make sure that these patients are getting the proper care and attention that they need. And all of the additional paperwork that goes with these things are all being done in a timely manner. We constantly talk about getting cell salvage because we think that giving the patients their own blood back to get their HB back up to 10 would be a winner, and we're working hard with people in theatre and other specialties such as obs and gynae in order to see if we can make a cell saver project more viable, so that it can be used for every hip fracture patient, as well as other specialties benefiting from our ODPs having that skill set. Enhanced recovery has become a new topic. We're trying to really improve our enhanced recovery so that these patients get up early, so that they don't get the chest infections, that they get home earlier. We're still asking for an INR pre-op bedside testing kit. Why? Because it's not we don't believe the labs can turn these things around, but we want to try and bleed our patients less. We can then prescribe in a certain way that means that they get their vitamin K earlier, to hopefully mean that we can get those patients optimized within the first 24 hours so they have a chance at being put on the list the next day. We're also working hard to staff our physio service better, so that it's not just really good from Monday to Friday, we've also got that excellent weekend cover, and I think these are all the projects that we're looking at to keep on improving, keep on maintaining as we go forward. And most of all, I would like to say a massive thank you to the whole team. This has been not just mine and Louise, we've obviously helped drive it along the way, but this has been the whole orthopaedic team, from the nurses on the ward to the theatre staff, to the surgeons that have operated, the consultants who have engaged with prioritisation, the orthogeriatricians, the physiotherapists, the occupational therapists in the hospital and the community. So we would like to say a massive thank you, and we'd also like to continue to challenge you to help us improve this service. So if you think there's things we can do better, tell us. We'll happily work with you to try and improve all of those things. And that brings me to the end. So yeah, it's hard work, sort of working out what the problem is, but the most important thing for me was to build the right team. And with that right team, we're now really starting to see the benefits of all the interventions that we've brought in. If you'd like to discuss them more in person, I'll happily go through them all with you. But and if anyone wants any help with any of their projects, we're very happy to help with quality improvement and see how, you know, what we did and what worked well for us. It might not fit for you, but you know, we're very happy to help. I'm not here today, but Louise will be happy to take any questions. But I would genuinely like to thank the Trust for this Quality Improvement Award on behalf of the orthopaedic team, and let's hope we can continue to improve our mortality and morbidity for hip fractures and build on the excellent team that we currently have. Thank you all. Did I press record? Yeah, that's all recorded now. Yeah. Thanks. Bye.
Hello, I'm Joyce Bradley. I'm Head of Quality Improvement here at Walsall Healthcare NHS Trust. Thank you for joining us to celebrate our Quality Improvement Awards for 2021. I've got one final award to announce today, and that's the first time that we're offering this award. It's for outstanding contributions to quality improvement. Going forward, it will be an annual award, but it's only fitting that this first presentation goes to someone who has helped all of us identify how we want to undertake quality improvement embrace it, support it, share it, and celebrate our successes, both here within Walsall and wider across the NHS. So, as an individual who's been recognised for improvements in innovation and engaging people nationally, we would like the Outstanding Contributions to QI Award to go to Dr. Hesham Abdalla. He was really key in establishing our Quality Improvement Academy and driving how we adopted quality improvement. It started back in 2017, and we actually held our first session in February 2018. We're sad that he's moving on, going somewhere else, but he's left us with a fabulous legacy that we intend to build on. Congratulations, Hesham. As we look forward, we expect to see more of you, more of the presentations that we've had today, the fabulous things that we've been sharing, more posters. Please give us the challenge of trying to work out how we present, support and promote all of the quality improvement changes that you're trying. Until we see you next time at either the Quality Improvement Awards or the QI Conference, take care. Good night.